and Michaela, recording. Thank you. Good morning, good afternoon, good evening, wherever you are, and welcome to this last WHO and TechNet webinar series on why gender matters for immunization. It's the second webinar series on this topic. The session today is about implement gender-responsive immunization services in emergency settings. So you can listen to this session in French, and you can also view the slides in French. So let's start with listening in French. To do so, please click the globe icon, which is at the bottom of the Zoom window, and select the language in which you'd like to listen to this session. So there's French and English. And now, please let me say that in French for our francophone audience. Vous pouvez écouter cette session en français. Pour ce faire, vous avez une icône en bas de votre fenêtre en forme de globe. Sélectionnez la langue et ensuite, vous pouvez choisir entre français et anglais. Ce sera pour pouvoir écouter la présentation, soit dans la langue originale en anglais, soit avec interprétation en français. You can also watch the slides in French or in English. And I see from the chat that some people see in French and some people see in English. To change that, you have a view option at the top of your window, and select Michaela for English and Stephanie for French, and you can switch and you decide. Let me say that in French as well. Vous pouvez voir la présentation en français ou en anglais, puisqu'elle a été traduite en français aussi. Donc, si vous voyez la présentation en anglais, que vous la voulez en français, vous avez un bouton en haut de votre fenêtre qui devrait indiquer option d'affichage ou view option si c'est en anglais, et choisissez Michaela pour la présentation en anglais ou Stéphanie pour la présentation en français. We'd be happy to know who's with us today, so please, you're very welcome to introduce yourselves in the chat box and tell us your name and where you are from. You can also use this chat box if you need any technical support. I'll do my best to help you. I suspect some people will join a bit later and might say that they see the slides in French or in English. So if they say something, you're welcome to help them and direct them how to change. I'll do it as well in case I see it too. If you have any question during the presentation, please use the Q&A box. So the Q&A box is at the bottom of your Zoom window. You can ask your questions at any point of the presentation, at any time, and the panelists will answer them either in writing perhaps, but at least at the end of the session during the Q&A session. Finally, this session is recorded and we'll share with you the links to the video as well as the slides by email, as we usually do. We hope you'll enjoy this session, and I give the floor to Stephanie. Stephanie, the floor is yours.
Thank you, Alex. And Michaela, let's maybe go directly to the next slide to start. So as Alex mentioned, this is the fifth and final webinar in this series. This series is part 2 of an ongoing overall webinar series that we've been running for the last year on why gender matters for immunization. So 10 webinars in total based on this guidance document, Why Gender Matters, Immunization Agenda 2030. This guidance document was co-published by WHO, UNICEF, and Gavi, and I hope by now everyone on this webinar has had a chance to look at this resource and flip through it. For those of you who weren't able to join us for previous webinars or interested in returning to the recordings or the slide sets, everything's available on our TechNet page. And this also includes the first 5 webinars, which were held last year. So all 10 webinars will be available there for you to refer to on that TechNet slide. Next slide, please. So as I said, these webinars are, based on this guidance document, and the point of this webinar or these webinars is to really bring to life some of the examples of gender responsive programming that we go through in this guidance document. And so for immunization, this refers to the gender-related barriers that might exist on both the demand side through people's health-seeking behaviors, as well as the supply side through the provision of health services. And as you know, all of us are focused on supporting immunization programs at one stage or another. We need to understand that in order to increase immunization coverage, it's necessary to understand and address the various different ways that gender interacts with all factors: socioeconomic, geographic, cultural, the list goes on. And all of this can bring together, a different lens with which to view how we can program to better improve access, uptake, and delivery of vaccines. Next slide, please. So each of the webinars in this series have focused on one of the examples of a gender-responsive approach to increasing immunization coverage, as highlighted in the guide. And we're looking to bring to you some concrete country real-life examples of how this has been applied to give some ideas and some texture to the content of this guide. So today we're focusing on implementing gender-responsive immunization services in emergency settings. Next slide. And we have two different presentations today, 4 speakers in total. We're very happy to have Simone Carter here with us from UNICEF Public Health Emergencies. She's the lead for the Integrated Outbreak Analytics Cell in DRC. And then we also have a presentation from CARE. We have 3 guests from CARE today: Niva Shakya, Cecilia Mbaka, and Santa Dangol, who will be taking us through an example of a rapid gender analysis conducted in Nepal. So I'm really excited for the presentations today. I hope you are as well. And we'll have time at the end for questions and answers. But please do, as Alex said, feel free to put comments and questions directly as the speakers are presenting. So just to set the stage really briefly, why is it important to implement gender-responsive services in emergency settings? So emergencies, and this can include outbreaks, disasters, conflict. Emergencies affect women, girls, boys, and men differently. So overlooking gender issues in emergency planning and response creates a danger for further entrenching gender norms and expectations that may already exist in these settings, and can create negative outcomes for women and other marginalized groups, particularly when they're already in a vulnerable situation as created by the emergency. So to be effective, immunization services must be responsive to this and address the different needs, priorities, and capacities of these people in emergency situations. And so understanding how to do so through some of these rapid gender analysis tools that we're going to be hearing about today can contribute really valuable data and help better target the immunization and other health interventions delivered in emergency services. We know that emergency activities during immunization activities, during emergencies can offer a platform to deliver additional support to particularly vulnerable populations. So integration is a huge aspect to consider here. And we're going to hear about how some of these tools can bring to light some of the key considerations that programs should be thinking about when designing their interventions. Next slide, please. So as usual, in the guidance document, we do have an action list that just gives some examples of different gender-specific or gender transformative ideas for working in these types of settings. So please refer to the guide for more detail. There's a whole section in there on that. I don't want to spend too much more time on it today because I really want to hand it over to our presenters. So with that, I will turn the floor to Simone, who is going to take us through the first country example. Thank you, Simone. Over to you.
Hi, thanks everyone, and such a pleasure to be on my call. So thanks for the invitation. I'm just trying to see if I can. There we go. Okay, so I'm just going to talk a bit through what is integrated outbreak analytics, how this links with gender integration, and provide some case study, but also some challenges that we have in this. So integrated outbreak analytics was developed here in the DRC, multi-actor, multidiscipline. So it's developed organically, WHO, UNICEF, CDC, MSF, Epicence, Red Cross. And it's really about a holistic understanding of outbreak and public health dynamics. And it's working through a process of good enough data, operational, so identifying what are the kinds of questions that we want to understand in an outbreak, having collaborative review and use of existing information. If additional information is required, doing a rapid protocol, collecting collaboratively, so with local actors, and always engaging those who are working in the program. So if we work with polio, and it's just an example I'll give, ensuring that somebody who is actually running polio programs is engaged from onset. It's about collaborative and integrated analysis and interpretation as well. So we can't pretend to interpret program data the same way we would interpret and understand biostatistics data or community source data. And all of that information, it speaks to each other, and we need to be interpreting it, understanding it together. And that's how we are consistently co-developing action. And so it's a process that happens in near real time. So in outbreak, like the monkeypox one that we are in right now in the DRC, it's, you know, from trigger question to co-development, it's a week. Ebola, when we started this 6 years ago in the DRC, it was the same. With polio, for example, it will take about 3 weeks to process. And so I always, again, it's about looking holistically. So when we think about epidemiological analysis, it is about thinking about all kinds of information. We tend to talk about data, as I just did, but what we really want is information, and information about, you know, population, health and services. What services do women or men access? Where? What is available? What are the trends in vaccination, but in malnutrition and deliveries in healthcare facilities? We of course want to understand what are the geographic and environmental or animal factors in that area. And of course, these will, like many others, you know, flooding, things like that, influence population health services, either delivery or accessibility. Understanding community economic landscape, so whether it's a community that is essentially trades or fishing or quite well off, etc. So we have gender and social dynamics as a part of information, but of course, it also, every single one of these pieces of information, they interact. And so they're not one or the other, they're just about interacting, and they're all, as we see, at the same level of importance. Understanding community behaviors and perceptions are also influenced by geographic, environmental, or changes in health services, as is healthcare worker capacity. And all of these are, of course, affected by geopolitical events or other types of events, whether it's volcanic eruption that we had in 2021 here, or whether it's border closures or school closures during COVID. And of course, these are all events that affect healthcare worker capacity, they affect community perception, they influence gender dynamics, and consistently tracking and monitoring programs. So what interventions took place and when, and how that these are interacting with cases, with perceptions, with engagement in healthcare services, as well as health outcomes. And so, yeah, gender influences and informs every single part of this information. Switch. Essentially, this is good epidemiology. So if we want to really understand health dynamics, we need to look at all of this. And so just to kind of take us back, so I've had a lot of discussions about gender and epidemiology, and the concept of integrating gender into epidemiology, or having gendered advisors in epidemiology or in public health. And if we're thinking about epidemiology, we should be looking at all the different distribution and determinants that affect one group or one population in one location. And those are all those pieces of information that we just talked about. And that's how we understand health risks. And when we look at a definition of gender, these are things that are affected as well by behaviors, norms, socioeconomic factors, and that change from society to society. And so they can't exist separately. And one of the things, and we'll kind of talk through this, one of the biggest challenges is that when we tend to say gendered integration, or adding a gendered analysis or gendered focus, it implies that we weren't doing that in epidemiology beforehand, which means that we weren't doing epidemiology beforehand. And so trying to rethink through what that really means and the language that we use about that when we're working with teams who are field epidemiologists, and among other mixed types of operational and health workers. So take you through a case study of how IOA works, or how integrated analytics works. So we've done looking at the recurrence of polio. So the Global Polio Eradication Initiative requested that we support to understand why, despite vaccine campaigns, in certain locations, we continue to have polio recurrence. And so, so we see, million kids vaccinated, and actually in the DRC, unfortunately, we've dropped 10 points in the most recent vaccine surveys. And so despite these, ongoing campaigns, these massive campaigns, and polio, available polio programming, we continue to see polio recurrence. And so when we looked at all these locations across these 3 provinces and 5 health zones, IOA is really about each health zone having its own individual context and dynamics. Of course, in areas where we tend to have polio and many other diseases, and unfortunately in many parts of the country still in DRC, we have poor wash conditions which can circulate and more easily circulate the virus. We also have limited health systems. We have higher rates. So for example, in Tanganyika province, the areas with polio have a 50% higher rate of malnutrition, 45% higher rate of diarrhea. And all of these things together with limited health systems can, of course, lead to disease. However, as this little map shows, so the orange at the bottom, that doesn't mean that we have polio everywhere. So how come in certain areas, even though across the country we have the same kinds of vulnerabilities or risk factors, it doesn't mean that we have polio everywhere. And so this is really because IOA is about the fact that dynamics really vary by events, as we said, by programs, past and present. Did we have free healthcare that changed? Did we have healthcare workers who were trained previously? Did we set up better maternal or child services? Did we provide strong training and engagement and support of healthcare workers, and genuinely support where most healthcare workers are either not paid or less paid? Did we support them to be able to do their jobs? What are community capacities? So when we talk about this, often we'll touch on it based on this, we tend to talk about, women's lack of education or communities' lack of ability or lack of engagement. But what is their real ability to engage? What is the dynamics of the interaction with their need to either work or access to services? How many times have 14% of women in one location were sent away because there wasn't enough vaccines? So those kinds of community realities as well. And then, of course, the responsibilities of men and women and children. And these are, again, at each level, we can see that they're influenced by the events, by the programs, by each other. So they're interactive. And so these, of course, need to be looked at in terms of what are these underlying causes. And these underlying causes are different in each location. And they might have similar, but it's how they interact together that really does change either vaccine engagement or exposure to polio and polio risk. And so we'll go through what looks like an ineffective first gender programming response cycles. So we see that polio continues to occur. And we look at what we consider like a contributing factor at one level. And so we'll say, we see in this graph, I know they're kind of small, what you'll see here, is the orange line is BCG. So if everybody know, your first polio vaccine, your first vaccines are polio and BCG, and often they are done together. And what we see is, this is the BCG level, this is the polio level, and this is the deliveries level. And so we're seeing that in areas where we have low delivery compared to, so we see healthcare facility deliveries are here, vaccination is here. So that gap shows us all the people who didn't deliver in a healthcare facility. And so we say, okay, well then higher rates of polio in these areas higher rates of polio, there must be an issue with, at-home deliveries. So the assumption is very quickly, well, we need to tell women, right? Women must not want to deliver. They must not be aware of the importance of delivering. And so we just continue to sensitize women to tell them how important it is to deliver in a healthcare facility. Often what happens is women feel unheard, disconnected, dismissed, and they continue to then not deliver in a facility. And we continue to have a cycle of not delivering in a facility, then not accessing or vaccinating your child in the first 2 weeks for polio. However, when we take a step further and we look at a little bit deeper of an underlying cause, what we see in a complete analysis, so when we're doing observation, when we're looking at facility services, when we're looking at what the programs look like, healthcare facilities, women are often not delivering because of the fact that the services are just not available. As we can see in these two photos of beds in the same location. And so if there's no water, if there's no sanitation, if there's literally no bed to be lying on or staying in, it makes it very hard for women to want to or be able to deliver in a facility. And so this massively changes our understanding of what is an underlying cause of polio exposure or polio associated risks. And that actually the action that needs to be taken is reinforcing the physical structure as opposed to continuing telling women that they need to go to something that is not available. This encourages women to feel heard, to feel engaged, to have a service that they're willing to go to, and changes, of course, it stops that cycle of ineffective programming. Another one that we see is that, again, the same kind of key one. So we're seeing polio recurring. The other one that we tend to say very quickly is that women aren't prioritizing. So we see that 17% of households or 20% of households, it's because of absence when we do that, the vaccine coverage surveys. The reason is absence. And so it must be, again, the assumption is the absence is because women don't think it's important, they're not prioritizing it. And again, we come to an action of sensitizing women on the prioritization and the importance of vaccination. What this leaves women with is a choiceless choice when they're trying to make decisions between working and having money to feed their children, or having money to access healthcare, or going to get vaccinated. And so again, this leaves us with children who continue to not be vaccinated or exposed to polio risk. When we look a little bit deeper at this, of course, we see they cannot afford to take time off work. So for example, 30% of women in one of the areas with polio recurrence were saying that if they did, they would lose income, and it was a choice between either feeding children, which if they have more than one, or vaccinating. So taking a step here is that also, even if you deliver in a facility in the DRC, that is not the moment that you get vaccinated. You have to go to another facility at another moment to get vaccinated. It doesn't happen on location. So it requires another transport, another time, and another moment to lose income. And so again, what this allows us to do is say, are we really, we talk about micro planning. We say that we develop plans at a community level. We are flexible to schedules, but when we mean flexible, we still mean flexible based on the days and hours that humanitarian or NGOs are supporting the healthcare workers to provide those services. We're not saying flexible as in mobile clinics to the potential agricultural location where they're working, or to or to creating evenings or very early morning times. It's still within a limit of flexibility and decision making. And despite the fact that the law says that vaccines should be available every single day of the week, this does not mean that they are. However, when we actually do make those changes, women are able to make both needs. They're able to both earn income, which is then used for food, decreasing both malnutrition rates, and increasing vaccination uptake and reducing transmission risk. And so just the last one, and this is something that is touched home quite a bit with us recently, is we tend to say that women are poorly informed. So we do a lot of surveys, and when I say we, across and in integrated outbreak analytics and in everything else, and we test knowledge, right? So we'll say, well, how many times do you need to, or what are the key moments to vaccinate your child? At what age? How many vaccines? We'll say very quickly, oh well, especially among women, especially in areas like the ones that we are with potentially lower levels of education. Well, women, they don't understand. They're not understanding. There's a lack of information, and so we make even big workshops saying, okay, we're engaging women and girls, and this is very, very focused on education and communication and making sure that they understand. It's an assumption based on the fact that women are either ignorant or uneducated, and that they don't know about the routine immunization. And so we continue to focus on messages that says, get vaccinated. And so what happens is that what we've now seen is women do not actually have the information about the different vaccines at the different moments, because we talk about 5 times vaccinating your child. There's no message or information that says you need 4 polio vaccines to protect your child correctly from polio. And so when we compared this actually to all of the different information that's available on routine immunization and on vaccines across all 5 locations, at less than 15%, and these are representative sampling of households, even received information on routine immunization. But as well, even in routine immunization, the message is 5 times to vaccinate. And so what we were actually finding, the post that we see here, it's get vaccinated, vaccination is love, vaccination saves your child. The messages they get in the campaigns are the same. The messages are often not even in Swahili or Lingala, but also they're not saying this is how many you need to truly protect. And what this led to is us realizing that, for example, in Manono, which is one of the areas where we have some of the highest recurrence still, despite 6 polio campaigns in a year, having over 100 cases, is 71% of parents thought their child was completely protected from polio. And when we compare them to the vaccine cards, only 14% of them were. And so false assumptions of protection based on information not being provided, but us analyzing in a way that consistently says it's just not understood. They don't understand. We have to keep saying the same messaging. Doesn't actually, those are the things that actually create distrust. And so what we're working through now, and this is a big change to think about, can we actually talk about how many vaccines to protect the child? And admittedly, the first argument is, well, there's not enough education, they won't understand. But actually, we've never seen a link. Well, there's low education and low knowledge. It's all we can see right now is no information has actually been given to demonstrate that they couldn't understand that. And so what we're really working through is, how do we actually provide the right information to be able to provide sufficient decision-making in terms of protection? And so one of the challenges I think with this is, sorry, this slide is a little funny. But when we look through, we bring up this information, and we've seen that we've done co-development, as we said, across every step. So this is all locally done. So we collect, analyze together with local actors. Everything is done through local actors and through Ministry of Health with polio groups. And we do co-development. But when we're doing co-development, out of all of the underlying causes and all of the 77 actions that have been co-developed in the last year, not one of them was about facility reconstruction or facility rehabilitation. It was all about communication, risk communication. Yes, some language talking. Yes, some potentially more information being provided. But the priority needs of systems changing, so changing the full way that we communicate on it, changing tools, or changing the water or the beds, or the larger scale changes that are clearly required when we see these through metasyntheses, remain very difficult for us to change. And so we did take back, and again, this is absolutely not a criticism to the program, but when we take back looking at the gendered barriers, they still remain, even at a healthcare facility or the healthcare facility discussion, they remain how women are treated. They remain the social interaction. They remain the behavioral side or the communication side, as opposed to there is no physical document that says, here's the information. There is no physical engagement in, or investment, sorry, in structures, in water, in beds, in everything that's women would need to be encouraged to go to a healthcare facility and deliver there. And again, it's so much on the interactions between men and women, or men and people, those working in healthcare facilities, as opposed to kind of also doing some of that more concrete hardware work. Okay, and so the other slightly big challenge as well, is the term gender doesn't exist in Swahili and Lingala. And so we're consistently talking about gendered integration into programming, and then we're frustrated, or from a evidence-based and trying to take evidence-based action side, frustrated on why we can't take more concrete action in terms of healthcare facility rehabilitation, beyond the RCC work. And then we understand, well, the word doesn't exist. So when we talk about gender integration, the only thing that can come out is, we need to communicate better for women because there's a lack of education. But there's also an issue for us, even in the fact that the word does not exist, the concept does not exist. So we are forcing a concept and forcing a way of working that we have to tack on gender. And so the only way people know how to kind of tack on gender is through RCCE, basically. We'll include women, we'll tell them more, we'll give them more information. And it's interesting, I have a team at Ministry of Health. We work through, the team that I work with is 99% Ministry of Health actors, and we've never done a gender training, but there's never not been gendered results and recommendations and evidence that comes out. But they would never think that the problem with healthcare facility infrastructure is a gendered issue. That would just come up as a health risk issue, an epidemiology issue, a transmission risk issue. And so we end up doing kind of evaluations. We did one recently where we said, how do you integrate gender? And it was like everybody pretty much failed the evaluation. But we say, how would you stop polio? And all of the recommendations are about maternal, child, and newborn health, strengthening in terms of services and in terms of more detailed available information. So exactly the evidence that we've seen here, but it would be considered a gendered action. And so I just want to see if I've got that one. Yeah. So, and just very last example is that, so instead, there was action that was done in terms of water, sanitation, and hygiene services set up in one province. So 41 healthcare facilities received a complete package of WASH. No additional training, no funding and payment of healthcare workers, but solar panel for electricity, running water, benches for pre and postnatal care services, beds, and there was in the last year and a half, where the rest of the country has seen a drop of a 10 point in immunization, there was an increase of 13% in the 72 hours after delivery, an increase of, I think that says 35% in the first polio, in measles, a 43%, and a 51% in DTC. So huge increases in the healthcare facilities that were supported compared to those that were non-supported. And this is how we can also show that actually infrastructure investment can have even bigger impact in vaccination sometimes. And again, nobody thought that this was a gendered action. So it's been a very interesting discussion that we've been having with the teams on those definitions. I think that's it for me. Thanks very much.
Thank you so much, Simone. A lot of really, really interesting content. I really encourage anyone who has any questions for Simone to please put them in the chat while we're going through the next presentation. And Simone, if you could head over to the Q&A chat boxes and sort of see what you can address, just in case we don't have enough time to get through everything at the end. But now I'm going to hand it over to our presenters from CARE to go through their slides. Over to you guys. I think Nima's starting. Or Cecilia, are you starting? Go ahead.
Yes. Good morning, good afternoon, everyone, and lovely to be part of this discussion. I will be building up on what Simone and Stephanie have already alluded to. Basically, how do we ensure that our immunization programming is gender responsive, and how to ensure that we are not overlooking gender issues. So today we are going to focus on one of CARE's tools that allows us to use a gender lens to understand the gender issues during crisis. Next slide. So then we have a tool that's called a rapid gender analysis tool. This is a tool that enables us to be able to understand through a gender lens
And Cecilia, sorry to interrupt.
Sorry.
You just hit me.
Oh, sorry. So then let me start over a bit. Sorry for that. One of the tool that we use in CARE is called a rapid gender analysis tool, which allows us to have a gender lens to analyze what are the roles and the responsibilities gender-wise that existed before crisis, and how has a crisis impacted this, to understand from a social ecological perspective, right from the individual to the family to the community and to the wider environment, the policies, participation and leadership, how the different genders are impacted, and how this gendered approach and the experience is affecting their access and the participation, especially to health products and services. It also helps us to understand what are the protection gaps and the needs, especially looking at gender-based violence, and how does this impact access to and the participation to health products and services like vaccines. And then by talking to the people affected and impacted by the crisis, we are able to understand what their needs are, what are the gaps, what are their capacities, and what are their coping mechanisms. All this to be able to align in the recommendations towards humanitarian actors, towards aligning the programming to be gender responsive to the people that are actually impacted by crisis. Next, please. So what does this tool actually entail? It understands the fact that during crisis, decisions have to be made quite fast to be able to respond to the needs. But then just because the response needed should be quite fast, and to be able to respond to this, the tool allows us to use existing data. So we can use secondary data, existing data, to be able to be fast, to understand what was the situation before. It allows us to be progressive, to be able to use what is available, to make initial proposals and recommendations, but then progressive in a way that we can add primary data to be able to speak to and to understand how the people that are impacted, the responders, the government, the communities, in terms of what they think the impact is and how we can program towards that. Then it's based on all this, it allows us to make very practical recommendations to the humanitarian actors on the ground on meaningful humanitarian responses. Next, please. So I've already talked to this, that the steps that the tool alludes to is being able to find available data, often humanitarian needs overviews, any existing gender, sexual aggregated data that is available, and then building onto that towards the progressiveness of being able to use primary data collection tools that allow us to talk directly to the beneficiaries, directly to the people that are implementing, and directly to the community that is impacted by the crisis, and then allowing us to triangulate this data in the analysis, understanding very well that this is a social tool. It's not meant for scientific significance. It does not, it doesn't call for statistical significance. It calls to using the information and the voices of the people that have been affected by crisis, and then writing this up to make practical recommendations for humanitarian actors, and then to share the rapid gender analysis with all the relevant actors on the ground, donors, humanitarian actors, community-based organization, the local organizations that we do work with. And then lastly, for accountability purposes, it has to be followed up by making sure that we are accountable to what the recommendations, to what the voices on the ground prioritize and mention to be the key needs and the key gaps and the key recommendations to what programming should align based on their needs. Next, we are going to look at how this tool has been implemented in Nepal during the COVID pandemic, and how this informed the programming around the vaccination for COVID. Over to you.
Thanks, Cecilia. I will be taking over and sharing the experience of rapid gender analysis done in Nepal for the COVID-19. Next slide, please. So with the rapid gender analysis, I just would like to start with the quote here, because we know that because of the various discriminatory practices, there is the effect of any crisis is very disproportionate. So as you can see in this anecdote that, during COVID lockdown, the workload for especially women and girls and daughter-in-laws increased in the household because consideration of household work as a domain for women. So the care work burden was added to women and girls at that point. And I also want to reiterate the former speaker, Simone, that she said that, women have no time to spare. So actually, this increased workload did add on to their, as a barrier to accessing health services as well. Next slide, please. So in Nepal, the rapid gender analysis was done in the lead of Ministry of Women, Children and Senior Citizen, and we partnered with UN Women and Save the Children. I would also like to highlight the fact that this kind of partnership does enhance a sense of bonding and a solidarity for having that gender lens into any response of any pandemic or emergencies. And we were trying to focus on the barriers on access and uptake and delivery of vaccination services for women, girls, and other intersectional identities, and also understand what are the differential impacts, as well as how the existing gender and social inequalities increased during the COVID crisis. And through this analysis, we tried to come up with recommendations for a more gender responsive COVID response plan. And these plans findings were shared widely with different clusters, ministries, and development partners, which also supported them to actually develop gender action plan and make their COVID response plan more gender responsive. And my colleague Santa will be adding more to the findings and recommendations and what actions were taken. Next slide. Primarily we use primary and secondary data collection in 12 districts, covering all the 7 provinces of the country. The secondary data review and analysis was a major part of it, which informed the primary data collection design as well. So 465 interviews were done with the vulnerable population. By that, I mean, lactating and pregnant women, adults and girls, women having daily wage work, returning migrant, men returning migrant, as well as women with disabilities and single women, woman-headed household. And we also did interview the government and non-government stakeholders. All of the interviews were done remotely through phone, but ethical procedures were followed. Next slide. Yeah, and in the RGA, we heard from the interviews, the key informant interviews, that how the decision-making autonomy is not there for the women, and their voice and participation is very limited in the spaces where decisions are being made. So my colleague Santaji will proceed with the findings and recommendations. Over to you, Santaji.
Thank you, Nivaji. Good morning, good evening, and good afternoon all. So I will briefly talk about how we use the finding of rapid gender analysis in COVID vaccination program during the COVID pandemic in Nepal. So here are some key findings of the rapid gender analysis. So yeah. As women are mostly rely and they are engaged in the informal working setting. So the rapid gender analysis found that unemployment rate has been increased at the time. So there as they are lots of the information channel during the COVID response time to COVID pandemics, and the women are mostly rely on the different informal communication channel. So the mostly the women have the lots of as well as the COVID things. So that's the the situation we found. And other things basic health services was not. Sorry, I think I'm audible. During the COVID pandemic situation, basic health services was also halted for the time being. That also created the problem for the women to get the basic health services as well as the other immunization the services from the public health facility. Next slide, please. So here are the key recommendations from the rapid gender analysis. It has recommended to engage the woman in the women network organization and basic in the COVID response program and the vaccination program as well. And it's also recommended to ensure that to provide the correct information to the women so that they will not have the misinformation about the vaccination and the COVID. So because of that they can get the proper the services and can visit to the vaccination site for the vaccine. And next. So it has, based on the rapid gender analysis, the as the health facilities were not, functioning properly, and it has also recommended, to provide the proper training to the health workers so that they can provide the basic health services to the women and children and other vulnerable groups. And it has also recommended the female community health volunteers to mobilize them as well as other the women volunteers and female volunteers to increase the awareness about the vaccination. Next slide, please. Yeah, based on this finding and recommendation, CARE has, the design the program and then also, adopted those findings in the CARE's response program. CARE supported the local government, to establish the cold chain systems so that they can they provide the vaccination at their doorsteps of the women and children. As our finding was that there is a limited, there was a some less autonomy of the women for the movement, and another things that they have to busy at home and they don't have time to go a bit far to get the vaccination. That's why we supported to establish the cold chain at the system, so that it can be provided at doorsteps. Another things that we also mobilize the female community health volunteers and other female volunteers as well to visit home to home to convince the woman and convince the woman and the adolescent girls about the vaccination. And they have the lots of misconception and myth about the vaccination. So that's this strategy has worked well, to convince them and bring them into the vaccination site for vaccination program, for the vaccination service. And definitely, we also supported the government, I mean the local government and health worker as well, to capacitate them, to recognize the gender barrier and in the community to receive the vaccination, as well as to address those barrier through the different community mobilization tool and programs. Next slide, please. Including here also, assisted the local government in conducting the household visit for the COVID-19 the vaccination. FCSB community volunteers were supported for the awareness and to address their myths and misconception about the vaccination and the COVID transmission. And also it has provided technical support to the local government to develop the gender responsive vaccination program and plan at the local level, so that they can address the different kind of barrier that we saw in the gender rapid gender analysis and get the women at the vaccination site. And in addition to that, the government developed the guideline, also developed the mechanism, different kind of coordination mechanism at different level of the government. And it also envisioned that women should be the part of that, the part of the coordination mechanism, but it was not implemented because of the so many reasons. So in our project area, we supported the local government and female community health volunteers, to be a part of that community. To part of that committee, so that it will be easier to address the issues of the women. And in the same way, we also try, through the different channel, as the women were facing the problem of the infodemic. So we also supported, to disseminate the message in different channel and the approaches for the correct information about the vaccination. Next slide, please. I think these are the source where we can get the information that we have done. And we can see the report as well in those links. Thank you very much.
Thank you so much. Thank you so much to all of our speakers for really, really rich and engaging presentations, and for making it through with a few minutes to spare for questions and answers. I know that there has been some activity in the chat. If you have any questions, please put them into the Q&A box so that we can answer them live now. Maybe, as we open the floor for any other questions to be added quickly to the Q&A box, I can just highlight one of the questions that was posed in the chat was around any tools or web paths on how to involve men and fathers in immunization matters at community level. And I just wanted to highlight that, that's a question that often comes up, and we did have an entire webinar dedicated to that subject a few weeks back, and some good presentations on work that's being done in that area. So I really do encourage you to visit the TechNet resource page there, and you can you visit that webinar. Any other questions? Maybe I see that Neva, you've answered one in the chat, but maybe you want to just answer that live in case people aren't seeing the response in the Q&A box. About someone asked about an ideal approach or strategy to include a gender lens. Neva, do you want to share your answer, and then Simone as well? We have time.
Yeah, sure.
Thank you.
So I think the key to this is really first the understanding of how, gender is at play. Like, for example, the women and the girls and people of different gender identities or sexual orientation are experiences these, different impacts. What are the things that are challenging them to access the emergency response or, emergencies like services, or what are keeping them from really participating in decision-making areas. So the first point is to really understand the specific barriers, to understand what are the key factors that is contributing to these challenges, and then to really devise solutions as per their, where they are, for the women, for the girls, for the men, for the boys, and for gender and sexual orientation, different orientation. So I think that lens, first of all, to understand the issues, and then to develop interventions to really cater to those issues would help to integrate gender into any emergency interventions. And thank you.
Thank you so much. And then also, I see that Simone had responded to that question as well, and particularly around this point about the need to really adapt to the local context. And of course, the example that she gave, that in some of the settings where the IOA has been working in DRC, the term gender isn't actually even, it doesn't even actually exist in the local language. And so you could be falsely collecting or doing a survey and people aren't actually understanding what you mean by the term gender. We also know that even when it's not a lack of vocabulary, a lot of settings that we work on, it might be sensitive to discuss gender in certain audiences. You might receive some resistance or some pushback. And so we've heard from previous presenters on country experiences around using terms like social inclusion or social justice or equity, talking more about the equity lens, which includes obviously gender as a component of the intersectional approach. And so it's really about understanding what works in the local context. And so I really appreciated that we had two very different examples today, from different settings, from different regions, and from different approaches that are working towards the same end goal. Unfortunately, we're going to lose our interpreter in 1 minute, so we won't have any more time for questions, but I love that there's been some engagement in the chat box today. And please, if you have any follow-up questions for our presenters, reach out, use the forum on TechNet to raise these questions as well. Everyone that's registered to this webinar series will receive this presentation and a link to where the others are stored as well. But we want to remind you that TechNet is also a forum for discussion, so you can raise questions there in the forum section, and create a community dialogue around this as well. I can't believe this is our last webinar in this series. So this is the end for this round at least, but please go back and check out any of them you missed. We'll be sending around a survey, a short survey to gauge your interest in this series and any other topics you'd like to hear focused on in the future. So, so keep an eye out for that. It will be coming. I want to say a huge thank you to all of our presenters today. Thank you so much for being here, and thanks to Michaela Manna as well, who's been coordinating all of this from behind the scenes, and of course to our TechNet logistics team that have supported this all. Alex, anything else before we close?
No, thank you very much. You said it all. So maybe just a reminder that I'm going to send an email probably early next week with all the links. Everything will be available on the TechNet platform, but everything will be also available from your mailbox. So thank you very much. And thank you very much for this collaboration. It was really, really pleasant and really interesting. Thank you.
Great. Have a good afternoon, everyone.
Bye,
Thank you, everyone.
Bye.
Bye.
Bye.